Barbara Shiknute, urologist, about prostate cryotherapy indications, performance technique, presentation of clinical cases. So, please.
So thank you. Last but not least, I hope. Um, I will continue this topic of focal therapy, of different techniques of treatment. So now I will talk about prostate cryotherapy, its indications, the performance technique, and I will present some clinical cases. So first of all, and the most important, is mechanism of action. So how does it work? First of all, cryotherapy causes protein denaturation caused by dehydration. Also, there is a direct damage of cell membranes with ice microcrystals. There's also ischemia caused by microthrombosis and vascular stroke due to microcirculation. All of these combine causes the cell apoptosis and tumor death. So, what is the aim of our report? Is to evaluate the efficacy of cryotherapy as the salvage treatment for relapsed prostate cancer after the radiotherapy. So a little bit about the procedure. The procedure is done by inserting 12 to 15 gauge cryoneedles into the prostate under the control of transrectal ultrasound. Inserting thermocouples at the external sphincter of the prostate and in Denonville capsule. Also, a urethral heating system is inserted. 2 cold freezing cycles are performed under the ultrasound control. The temperature of minus 40 degrees is reached in the prostate. In the rectum, the temperature must not be lower than 0 degrees. So here is a picture from the procedure. As you can see, the patient is under general anesthesia in a lithotomic position. We can see the brachytherapy grid. We can see the needles inserted into the prostate. And here is a view from echo. So the first picture is from a sagittal plane. Needles are inserted until the base of the prostate without damaging the urinary tract. And the actual axial view shows the prostate with the needles through the view of a brachytherapy grid. Again, some pictures from the procedure. So first of all, when we start the freezing cycle with the gases, the fast freezing and heating cycle is around 20 to 30 minutes. It is done twice. We can see on the picture the hypoechogenic zone, which is the ice ball of the procedure. So different size of a needle gives a different size of the ice ball, and it is between 1 or 2 centimeters. So with the help of a cystoscope, we insert the heating system into the bladder. With the urinary catheter placed passively into the bladder, we warm it up. We warm up the prostate after the 2 cycles of freezing procedures. So how to choose your patient for this treatment? First of all, patients in low risk, who have a PSA under 10 nanograms per milliliter, who has a Gleason score under 7, with a clinical stage of CT1C and CT2A. Also, medium risk patients with the PSA between 10 nanograms per milliliter and 20. Those who have a Gleason score of 7, and with a clinical stage between CT2B and CT2C. Also, the prostate volume should not be over 40 milliliters. The IPSS score should not exceed 12, and life expectancy should be more than 10 years. So our experience in National Cancer Institute, we have performed 6 salvage cryotherapy procedures. We had 3 procedures in 2012, 2 procedures in 2013, and 1 in 2014. So the follow-up, 2 months after the cryotherapy, the PSA level was ranging between 0.002 and 1.77 nanograms per milliliter. So we jump forward a little bit. In 2019, the PSA was ranging between 0.33 and 10 nanograms per milliliter. Until now, we did not see any local recurrence on MRI and no metastasis in bone scintigraphy. So MRI is done once every year, and the PSA every 6 months after the procedure. So one patient 4 months after the cryotherapy had a rising PSA from 1.77 to 21 nanograms per milliliter. MRI showed a pathological lymph node in left pelvic area. Its size was 13 on 20 millimeters. Patient had received 60 gray external beam therapy to the lymph node projection, and PSA dropped until 0.9 nanograms per milliliter after the radiotherapy. So we discuss a little bit about the clinical case. We have a patient of 68 years with the prostatic carcinoma CT2B and 0M0, Gleason score of 6, 3+3, and post-radiotherapy treatment. Anamnesis. In 2006, PSA was at 18 nanograms per milliliter. On digital rectal examination, we have found CT3. On prostate biopsy, there were 6 positive samples for adenocarcinoma Gleason 6, 3+3. No metastases were found on chest X-ray or bone scan. In 2006, androgen deprivation therapy was initiated, and in 2007, he received the 70 gray dose radiotherapy to the prostate. So later, after the radiotherapy, his PSA dropped to 0.7 nanograms per milliliter. And in 2011, it started rising again until 5.8 nanograms per milliliter. In 2012, pelvic MRI showed prostate volume of 26 milliliters. Extracapillary extension at the left side was seen. A urinary bladder and rectum did not show any pathology. No pathological lymph nodes or metastases were detected. So androgen deprivation therapy was started once again. The PSA dropped until 0.16 nanograms per milliliter, and ADT was terminated. So after the initiation of ADT, in 2012, prostate salvage cryotherapy was performed. After the procedure, a patient had a urinary retention. We have done a cystostomy for him, treated the infection, and his PSA was at 0.02. So 6 months after the cryotherapy, patient underwent the transurethral prostate resection for the urinary problems. Histology came back for prostate tissue with necrotic areas, mixed inflammatory inflammation. However, no residual tumor was found. So these are the images from the transurethral prostate resection after the cryotherapy, and we can see the necrotic tissues, but no signs of residual tumor. So in 2014, PSA level was at 0.3. On MRI, no local recurrence was detected. In 2016, PSA was at 1.3, and on MRI we have seen a suspected bladder tumor. But in the prostate there was no tumor recurrence. At this point, patient had intermittent hematuria, and in 2016 he underwent transurethral resection of the urinary bladder. Histology came back for urothelial papillary carcinoma PTA-G3 with nonspecific changes in prostate tissue. So 6 months after, we have repeated the transurethral resection of the bladder. No cancer recurrence was found, and cytology came back for reactive urothelial changes, and as well for infection of the bladder, which was later treated. So we continue with this patient until now, and in 2017, 18, 19, there was no local recurrence of the prostate cancer on MRI, and his PSA was ranging from 0.4 to 0.6. Clinical case number 2, it's from a patient of 63 years with the PSA growing from 2.6 until 5.37 nanograms per milliliter. Prostate volume of 54 milliliters. The patient underwent 3 negative transrectal ultrasound controlled prostate biopsies in 2010, 12, and 14. They were all negative. So his IPSS score was 3 and erectile function between 15 and 20. Pelvic MRI in 2014 showed prostate of 50 milliliters. Pyroid's 3 lesion was found in the left transitional zone. The tumor size was of 0.4 cubic centimeters. And so here we see the prostate picture, and this is the location where we have found the lesion. So transperineal prostate biopsy was performed. A saturation biopsy of 24 cores by brachytherapy grid was performed. At the point 2E, clinically insignificant prostate cancer was found. So here we see the answer, that there is there is one node, Gleason 6 3 plus 3, in the left lobe. Its length of 0.5 millimeters, and no lesions were found, no suspicious lesions were found in the right lobe. So, treatment options for this patient, we had active surveillance, we had radical prostatectomy, and radiotherapy. However, a patient has refused from all these treatment modalities due to complications, urinary continence, erectile dysfunction, and also, the active surveillance tactic was unacceptable for the patient. So let's see what the guidelines of 2015 could offer us. So, in patients who are unfit for surgery or radiotherapy, cryotherapy or HIFU might be an alternative treatment of prostate cancer. This is taken from 2015 guidelines. So what we have done, so what is the difference between the guidelines now is that the other options of the treatment, like HIFU or cryotherapy, are used only within the clinical trial settings. So the guidelines has changed over time, but the treatment was performed in 2015. So we have performed focal cryotherapy for the prostate lesion. In 2015, focal prostate cryotherapy was performed. 2 thermocouples were used, in one in the left lobe of the prostate and the other one in the Denville capsule. Single 15 gauge freezing needle was used. 2 freezing cycles were performed under ultrasound control, at which the temperature of minus 40 degrees was reached in the prostate. And temperature in the rectum was kept at plus 17 degrees Celsius. So again, a picture from the procedure. We see the ice ball and we see the needles. So the conclusion is that our initial experience shows that cryotherapy is an effective alternative, minimally invasive option for the treatment of locally recurrent prostate cancer after radiotherapy. However, the short-term data seems to be promising, but longer term follow-up is absolutely necessary to verify the oncological and functional results. So thank you very much for your attention. Do I have any questions?
Thank you. Thank you very much. Takimas is here.
Thank you, Barbara.
Thank
Yeah.
you. Any questions? Any questions?
I don't see questions on the slide though. Yes, but maybe we can ask something, Algirdas. Yeah. Do we have time for one question?
We have a lot of time. Not
Yeah.
for one, for a lot of questions.
So, Barbara, that first patient with salvage cryotherapy, what was the PSA of that patient, PSA doubling time for that patient after the radiotherapy?
I must look it up. I cannot tell you just like this. I actually have to look it up.
But if because the PSA after the cryo it dropped, but not to the zero. So I think we have somewhere some cancer cells in that patient, but they are not very aggressive. It could be 3+3, and then they could grow for 20 years, and the patient will be alive without any symptoms. So actually, yes, we can be very, very aggressive and make a lot of problems for that, but still we can also help for those patients.
I think,
And
as we discussed before, there's a lot of patient-doctor discussions going on. There's many, as from the second case you've seen, that the patients are often pushing you a little bit to take more steps and to find the alternatives. So really, it's about at this point what has happened between the patient and doctor is also very, very important.
yeah, but actually, as you showed us the guidelines, new guidelines, actually, if the patient would be today and he would rejected the radical treatment, the prostatectomy or whole prostate irrigation therapy, I think it won't be so easy to treat that patient with focal therapy.
Yeah, I think it would be more difficult now.
The only this the clinical trial that could be uh, initiated, and then the patient could be ablated with cryoablation. Actually, in this case, it's ideal case for ablation because we can see the tumor. It's not very aggressive, and we needed only one needle, I think, yes, for ablation. So it's even of course there was two thermocouples that cost money, but still one needle is not 12 needles that cost a lot of money. So I think yes, that was a good solution of the patient.
Yep, I agree.
So thank you very much,
Thank you.
Barbara.